Maybe train.
ठीक है, वी आर गोइंग लाइव राइट नाउ. ओके, ध्वनि आप अपना ऑन कर लीजिए. So, good evening, everybody, and welcome to this MedEClasses lecture series on delayed puberty in girls. And this is part of our initiative, a monthly initiative, in which we propose to cover the entirety of pediatric endocrinology from a pediatrician and pediatric trainee perspective over the next 36 months. I'm pleased to be joined by Dr. Vibha, who is a consultant in pediatric endocrinology at Regency Health, and Dr. Dhwani, who is a fellow with us at Regency Center for Diabetes, Endocrinology, and Research. So this is a very, very important topic. And what are the key things, Dr. Vibha, you have to understand in terms of when you are evaluating a girl with delayed puberty compared to boys with delayed puberty?
So most in compared to the boys, the presentation, the cause of the delayed puberty in girls is mostly physiological, is not physiological in comparison to boys. So we have to firstly rule out the systemic causes and other pathogenic causes or the organic causes in comparison to boys.
So although we have got lesser number of girls who come to us with delayed puberty, we need to be more worried about that in that perspective. So Dhwani, in your experience, what are the common presentations or common causes of delayed puberty of girls?
So again, as ma'am has mentioned that when you have a girl with delayed puberty, you have to be wary of it being a pathological cause. However, we've seen that about 1/3 of these children are actually physiological and self-limited delay of puberty. However, the most common causes that we encounter are probably hypothyroidism, Turner syndrome that we commonly see in our day-to-day clinical practice.
So celiac, hypothyroidism, Turner syndrome, these will be a very, very common causes in that regards. So we'll try to cover the entirety of delayed puberty in girls. We will start off with a bit of pathophysiology, then move in terms of etiology. And then from there, we will talk about assessment and management. And in the end, Vibha has prepared some very interesting OSCE, the objective structured case examination, which will test whatever we have been able to give the message around or not from that perspective. So delayed puberty, as we've discussed, is an important cause and something which we have to be concerned about in terms of evaluation and management, but we have to also keep a balance that we don't do an undue evaluation. So we have this 13-year-old girl who had presented to us a few years ago with concern for delayed puberty. She had stage 1 breast development and stage 1 pubic hair development. So parents were concerned that she was not having puberty. She was short for the age, weight was reasonable, and somebody had done a workup which showed a low level of LH and FSH. To compound the matter further, ultrasound had been done by the referring physician who found an absent uterus. Now, this was a very devastating scenario for the parents. They were very concerned about the puberty, breast not being there, and ultrasound showing an absent uterus, which was an entirely disastrous scenario from that regards. But what we need to understand is that 13 years is just the edge in terms of the time when puberty should happen. And in this scenario, clearly we need to understand that when the breast is developing, the uterus will take time to develop. And at breast stage 1, we can often miss a uterus on a transabdominal scan. So this case really highlights the importance of not doing unnecessary workup like ultrasound. And this case better would have been to wait and watch. And this is what we did. And the girl had a normal outcome subsequently. The second scenario was a 14-year-old girl with delayed puberty. Now, this is from a different perspective and dynamics. She had presented with stage 2 development with pubic hair stage 3. So what looked like that she had some development to begin with. This is what the parents said. And then the development had stopped for the last year or so. Again, the same thing was found. LH was 0.1 and FSH was 0.1. And people thought that, okay, like the first case, better to wait and watch. This was labeled as constitutional delay. Now, as I'll talk subsequently, that when somebody has a stalled puberty, it has got an entirely different connotation as compared to a classical case of delayed puberty in girls. And in this case, we should be worried about an underlying cause which was missed. And she presented later with seizures and glioma. So there seems to be a quick balance with regards to not doing unnecessary workup in delayed puberty on the one hand, like in the first case, but also to not miss a cause, which is very important. This is what we'll try to focus over the next hour or so, is to develop clinical pointers to suggest pathology and do a reasonable amount of workup without overdoing it to identify the cause from that perspective. Now, delayed puberty, as we discussed, is common in girls. Approximately 2.5% of all girls have delayed puberty. As Dhoni was talking about, 30% to 40% may be physiological, but we can have other pathologies like hypogonadotropic hypogonadism, less common as compared to boys. Functional causes like malnutrition, systemic illnesses, more common in girls compared to boys. And of course, hypogonadotropic hypogonadism with Turner syndrome leading the list is definitely common in that regards. So our role is to not unduly investigate these 30 to 40% with physiological causes, but not miss these 60-70% who have a pathological cause in that regards. All of you should go and have a look at our website, learning.growsociety.in, which has got a lot of resources with related to pediatric endocrinology, including a number of video lectures which are available and courses in terms of that. We have our e-learning platform on YouTube, which has got a large number of videos as well. And we have got validated courses in terms of pediatric endocrinology, including a full hybrid fellowship program of a 2-year program, specific pediatric endocrinology course for postgraduates, which is also available. We have got a full spectrum of books ranging from pediatric endocrinology protocols, which guide the pediatricians and pediatric trainees for basic workup, to basic pediatric endocrinology, which is covering pathophysiology as well, and advanced pediatric endocrinology covering the entirety of pediatric endocrinology. Our mobile application, which I'll touch base later, is one tool which helps in terms of point of care management in that perspective. So today we're going to focus on delayed puberty in girls. We already recently had series on precocious puberty in boys and girls. That's available as part of our YouTube channel, and you can go and have a look at it. I am joined, as discussed, by Dr. Vibha and Dr. Dhwani, who will be focusing about different aspects of delayed puberty evaluation from that regards. Now, hypothalamus pituitary ovarian axis is the crux in terms of pubertal development. So we've got the GnRH, which is produced by the hypothalamus, which is the trigger of puberty. This GnRH is under the stimulatory and inhibitory signals. So the signals glutamate and kisspeptin stimulate, and GABA and MKRN3 suppress the pubertal development. Variations which happen in terms of these have an outcome effect in terms of pubertal development. Now, this GnRH, once we have got enough time and the body is mature, the inhibitory signals go off, goes to the pituitary to produce two important gonadotropins, the LH, which acts on the LH receptor in the theca cell to produce androstenedione, and which is subsequently aromatized under the effect of FSH in the granulosa cell to estrogen. Estrogen is responsible through its action on the estrogen receptor 1, ES1 and ES2 in terms of the breast development, the bone growth maturation, as well as the uterine growth. Importantly, adrenals produce DHEAS, which is the source of androgens and are largely responsible for pubic hair development in girls. And this makes pubic hair an important discriminatory factor in terms of etiology of delayed puberty. The adipocytes are an important source of regulation of puberty, and only if the adipocytes are sufficient, which is indicated by a level of leptin, would the body pass the toll gate of puberty. So if you have a child who is malnourished, who has got low amount of adipose tissue, less amount of leptin, the puberty will not start, and if it started, it will stop at that point. And therefore, malnutrition and systemic illnesses are important causes of delayed puberty in girls from that perspective. So this is how the leptin works. Now, when we assess puberty, we need to understand that we have to assess breast and pubic hair development separately. And then when we combine them, we get a clear idea in terms of the accurate picture of the clinical scenario. So we all are aware about the different stages of breast development. We know that breast stage 2 is the one which starts the puberty, that's the papilla elevation. We have to distinguish it from lipomastia because that could be because of obesity. So you approximate your thumb and finger and look for the resistance. If there is resistance, there is a breast tissue. Otherwise, this is suggestive of a fat tissue. This is the point where the growth spurt happens. And if you have delayed puberty, you do not have a growth spurt, and therefore the girls will be short. Breast stage 3 and 4 mean that you're coming close to menarche, and typically there is a 2 to 2.5 year gap between the thelarche and menarche. If the gap is increased also by beyond 3 to 4 years, that is an indicator of a stalled puberty. And from a clinician perspective, I am worried about delayed puberty, but I am doubly worried in terms of a stalled puberty. So if I had a girl, like in the case 2, had some development to begin with, and then the development stops, that's an even major cause of concern in that perspective. Now, pubic hair do give a lot of clue in terms of diagnosis because they come from a different organ altogether, the adrenals. So what we are really looking at is not really P2, which is just bigger than vellus hair, short, straight, and light. We are mainly worried about whether the P3 has developed or not. And if there is a discordance between the pubic hair and the breast development, that really gives us a clue in terms of the diagnosis. So P3 means basically that you have got longer, thicker, curly, and pigmented hair, which means definite androgen exposure has happened. And then you go from the subsequent breast pubic hair development in that perspective and regards. Now, if we now look at in that perspective of the pubertal development overall, we now understand that there is a differential regulation which happens in terms of our breast development and in terms of the pubic hair development. And this has implications in terms of how we should proceed in terms of evaluation and management. So the ovaries, under the influence of LH and FSH, as we have discussed, produce estradiol, which is responsible for the breast and the uterine growth. On the other hand, adrenal, under the influence of ACTH, produces DHEAS, which regulates the pubic hair growth. So depending upon your disorder, you will have differential expression of thelarche and pubarche. So 4 conditions: constitutional delay of puberty and growth, systemic illnesses. Of course, this will be having an effect both on estradiol production and DHEAS production. If somebody has a multiple pituitary hormone deficiency, they cannot produce ACTH, the DHEAS will be less. And if there is a steroidogenic defect, this is a rare scenario, will have both absent breast development and absence pubarche. So absence of pubarche in a girl with delayed puberty points predominantly to constitutional delay of puberty and growth or systemic illness. Likelihood of MPHD and steroidogenic defect is already there also in that regards. However, if there is an isolated hypogonadotropic hypogonadism, a GnRH deficiency, the ovaries are not working, but the adrenals are doing fine. So in this scenario, you will have a normal pubic hair. Apologies for the disconnection. So pubic hair development, we're discussing about the correlates with regards to the pubic hair development and the breast development. And in this scenario, if we look at the overall correlate, as we discussed already, that you have got differential regulation as terms of ovaries and the uterine development and the breast development, which is regulated via the ovaries, and the adrenals are regulating the pubic hair growth. So in scenarios where you have got defect affecting both of them in the form of constitutional delay of puberty and growth, systemic illness, multiple pituitary hormone deficiency, and serologenic defects, there would be an effect of both ovaries as well as adrenals. There will be no breast development and no pubic hair development. However, in scenarios where you have a specific problem with regards to if you have a specific problem which is affecting the GnRH neuron, in that scenario, you will have a problem of the effect will predominantly be on the ovarian production. There would not be an effect in terms of adrenal production, and there will be a normal pubarchy. So if there is no breast development but pubarchy is present, you are thinking more in terms of a GnRH deficiency. If there is a problem in which the estrogen is being produced from aromatization of the androgen, but the androgens are not acting, the individual will have typically a good breast development, but the pubic hair development will be sparse. So this differential of breast development but not having pubic hair development is a typical scenario of androgen insensitivity. And finally, if there is nothing wrong in terms of the ovarian function or in terms of the adrenal function, there may be a normal amount of breast development and normal amount of uterine development. So there will be normal breast, normal pubic hair, but because there is a Mullerian agenesis or there is an obstruction, there would be no periods in that regard. So that would be a malformation. So no breast, no pubic hair is suggestive of a constitutional delay of puberty and growth, systemic illness, or MPHD. If there is pubic hair but no breast development, that's GnRH deficiency. If there is breast but no pubic hair, that's androgen insensitivity. If there are breast and pubic hair but there is no vaginal bleeding, that suggests a uterine malformation in that perspective. Now, the hormonal progression typically is that the FSH levels are usually higher in the prepubertal age group, but the LH level increases by around 10 times more as compared to FSH levels. So LH is a much better indicator as far as the pubertal development is concerned. We need to remember that as time progresses, the bioactive to immunoreactive ratio will also be more in that regards. Now, growth of pelvic organ is also very important. And if you notice that at breast stage 1, the uterine volume is very, very small. It's like a paper thin structure. It's a straight tubular structure. As the breast grows, the estrogen levels goes. It changes into a globular structure. From tubular to globular, the length increases and the volume increases in that perspective. So what we need to understand clearly is that if there is no breast development, the uterine development may also be defective in that perspective, and that's an important cause of concern. So now in this perspective of the hypothalamic pituitary gonadal axis, we can understand the pathophysiology of delayed puberty. Problems could be at the level of the hypothalamus, which is hypogonadotropic hypogonadism, characterized by low levels of LH and FSH. Or the problem could be at the level of ovaries where the FSH levels will be high. This is hypergonadotropic hypogonadism. Hypogonadotropic hypogonadism typically can be because of a physiological cause, 20 to 30% cases, a genetic cause, a trauma, or any form of insult or infiltration, including tumor. So any girl who has delayed puberty with low LH and FSH, we have to really worry about pathological causes once you exclude the systemic illness, CDGP, and the other basic causes like functional disorders. Hypergonadotropic hypogonadism, the most common cause is gonadalogenesis in the setting of Turner syndrome. And in this regard, we also have to think of serologenic defect. Here, a karyotype becomes extremely important. So now we will move forward. We've discussed about the pathophysiology. We will now move forward in terms of the overall aspect of the etiology. And for that, I'd like to hand it over to Dr. Dhwani to please carry forward from that.
Is my screen visible, sir?
Yeah, please go ahead.
Okay. Thank you so much, sir. So having understood pathophysiology, it will be much easier to understand the etiology now. So as we've already seen that about 1/3 of these girls are have a physiological cause of delayed puberty, which is self-limited. And however, significant proportion of these can also have a pathological cause, which need to be taken into account. Uh, Pathological causes can be in the form of hypergonadotropic hypogonadism, which results from ovarian dysgenesis. The most common cause encountered in clinical practice is the X0, that is the Turner syndrome phenotype. It can also be because of an acquired ovarian insult, as may be seen with autoimmune conditions, post-cancer therapy, or post-infections, or due to steroidogenic defects. The other spectrum of pathological cause of delayed puberty is hypogonadotropic, which could again be functional cause due to malnutrition, systemic illness, or hyperlactin levels seen in 10% of the patients presenting to the OPD, or it can be permanent pituitary hypogonadotropic hypogonadism. Again, this may be associated with multiple pituitary hormone defects or isolated defects as seen with KIS1, GnRH, FGFR, and CAL1 mutation. The important clinical pointers will include in your self-limited form, functional forms in MPHD. These children will have neither pubarchy nor breast development and will classically be short to begin with. Whereas your isolated hypogonadotropic hypogonadism as well as your hypergonadotropic hypogonadism, the only part defective is your estrogen synthesis, whereas your adrenals are working fine. So these children will have some pubarchy and pubertal progression. As is expected, lab tests will show low FSH levels in the hypo and self-limited functional forms, whereas hypergonadotropic hypogonadism will present with high FSH levels. CDGP, again, less common in girls, but you will find a classical family history of delayed menarche in mothers or delayed shaving or growing until a later stage in family. Is seen in 50 to 75% of girls with CDGP, and it is acquired in an autosomal dominant manner. Genetically, there are certain gene defects like IGS10, FTO, which are associated with a delayed, self-limited delayed puberty. Because in the stage of mini puberty, these children are exposed to GnRH pulses and increased FSH LH levels when a GnRH agonist test is given. So although their basal LH levels may be low, after a GnRH stimulation test, their LH levels will classically be more than 5 milliunits per liter, whereas in those with permanent hypogonadotropic hypogonadism, the levels are usually less than 1 milliunits per liter. Similarly, to treat CDGP, low dose of estrogen are given because they will ultimately lead to some bone age progression, which will increase your GnRH pulse frequency and cause a pubertal progression. So as we know, CDGP is self-limited in most cases resolved by 16 years of age. Growth in bone age are, although delayed to start with, ultimately catch up to the family expectations. In children with psychosocial impact because of delayed puberty, one may give a short course of low-dose estrogen. So the management will include observation versus giving low-dose estrogen in these children. Now, we also know that our GnRH neurons originate in the olfactory plicord along with the olfactory neurons and then subsequently migrate to the hypothalamus. Certain gene defects like LIF, AGF are responsible for GnRH neuron development. FGF8, FGFR1, CHD are responsible for their initial migration, whereas PROC2, PROC2 receptor and anosmin are responsible for their further migration. Defects in any of these genes will result in isolated hypogonadotropic hypogonadism along with plus minus variable as seen with FGF8 and FGFR1. There may be variable anosmia seen in these conditions. CHD7 is seen with Chart syndrome, so you will have coloboma, heart defects, hearing defects, genitourinary problems, the complete syndrome. Similarly, PROC2, PROC2 receptor and anosmin are associated with anosmia and isolated hypogonadotropic hypogonadism. And IGS10, as we've already seen, can range from a spectrum of CDGP to hypogonadotropic hypogonadism and is often self-limited with resolution. to see. Functional GnRH deficiency, again, as we've seen, is hypothalamic. Your body is going back into the prepubertal stage, a shell region. The major cause is because of low leptin reserves, seen with malnutrition, especially in the setting of anorexia nervosa, seen in athletic females with who exercise a lot. This extreme exercise and malnutrition result in a negative energy balance, and which may be seen along with a low fat intake in these children. So in the presence of low leptin levels, your body wants to conserve energy and does not want to spend it on pubertal progression, which is an energy intensive process. When your leptin levels are low in the setting of sudden weight loss of 10% or a total body fat of less than 20%, your GnRH pulse frequency will decrease, resulting in low LH-FSH levels, which will go back to your prepubertal pattern and resulting in therefore decrease in ovarian hormone production. Along with this, you will see a decrease in T4 levels because your body is trying to reduce your basal metabolic rate. There will be an increased GH levels, mainly to compensate for, to allow glycogenolysis and gluconeogenesis to allow adequate glucose availability to tissue for metabolism. Similarly, in the case of malnutrition, or any long-standing stress, you will have increased CRH levels, increased cortisol, which will again interrupt with your GnRH pulse frequency. Calvin, FGFR, GnRH receptor, and PROCAR2 again are hypothalamic causes, which will interrupt with your pulse frequency. So these conditions can present with a primary delayed puberty or primary amenorrhea. Hypothyroidism is an important cause of delayed puberty. So when you have hypothyroidism, your TSH levels go up, your TRH levels go up, which result in an increased prolactin levels, which suppress your GnRH pulse frequency, resulting in low LH-FSH levels and reduction of further progression of puberty. We've often come across children with delayed puberty who are never investigated for thyroid problems, are investigated, however, for prolactin. Their prolactins come up high. They undergo MRI neuroimaging, which shows pituitary adenoma, but it is actually your thyrotroph hyperplasia, resulting in an increased sign of increased size of pituitary, which is identified as an adenoma. So in such conditions, ruling out hypothyroidism is extremely important. While these children can present with anovulatory cycles, delayed puberty is also an important presentation, and coarsening of hair is seen. Classically, these children will have multicystic ovaries and may falsely be labeled as polycystic ovary disease and be treated with cycles of E+P for a prolonged duration without correction of the primary pathology. Hyperprolactinemia is an important cause of what I would say is secondary amenorrhea usually, but may also be seen with primary amenorrhea. Hyperprolactinemia presenting with delayed puberty is extremely rare. Common causes of hyperprolactinemia that one may see in clinical practice could include a prolactin-producing tumor, the prolactinoma. Usually, the prolactin levels are more than 200 nanograms per ml in this condition. Or you can have hyperprolactinemia because of stalk lesion. So any cause causing a stalk interruption will result in loss of the negative feedback from dopamine, resulting in increased prolactin levels. The prolactin levels seen in this condition are usually less than 100 nanograms per ml. Hypothalamic lesion of any cause, especially radiation, may again result in the loss of dopamine negative feedback and have similar prolactin levels of less than 100 nanograms per ml. An important cause of hyperprolactinemia that you need to rule out, especially in someone with primary or secondary amenorrhea and high estrogen levels, is pregnancy. You will have high estrogen, high prolactin, but suppressed LH-FSH levels in these conditions. And usually the prolactin levels may go up to as high as 400 nanograms per ml. There are certain drugs, especially antipsychotic, prokinetics, and SSRI antidepressant drugs, which may again be your dopamine receptor antagonist, resulting in increased prolactin levels. And these levels can again be as high as 200 nanograms per ml, confusing with your prolactinoma tumor levels. And you need to be sure of taking the rightful drug history before you make any diagnosis. Hypothyroidism is again an important cause. It is the high TRH level, which is causing increased prolactin production. The prolactin levels here are usually between 50 and 100 nanograms per ml. Uh, Slight or mild increase in prolactin levels is also seen with liver disease and renal failure, and they need to be ruled out when evaluating a child with hyperprolactinemia. Usually, the levels in these conditions are between 20 and 50 nanograms per ml. When you have a child with hyperprolactinemia and you've ruled out all other pathology, you need to go for neuroimaging, and your neuroimaging can show multiple scenarios. So you can either have a macroadenoma, which can be your prolactinoma. Here, what you can see is a section showing a pituitary macroadenoma with a figure of 8, which is uh, crossing your optic chiasma. It is pushing over your optic chiasma and ascending into the suprasellar space. It is also causing laterally bony erosion of the sella. Or you can have mass lesion with stalk thickening, classically seen with autoimmune hypophysitis. In adults, the most common presentation is with ACTH deficiency. So they'll come with lethargy, weakness as the common presentation, whereas in children, growth hormone deficiency is often the most common presenting symptom. Or you may have a craniopharyngioma, which is a suprasellar mass ascending downward into the um, sella. Classically, as can be seen with, if you compare case 1 and case 3, you can see that case 1, where your mass is arising from the sella and going into the suprasellar space, you can make out a snowman or a figure of 8 appearance, which is not apparent in the third scenario. You may have pituitary cyst, Rathke cyst, or pituitary cyst or Rathke cyst, which are again fluid-filled cavities, which may cause stalk compression and mild hyperprolactinemia. An important cause of a stalk lesion could also be a germinoma, which are synchronous lesions. You may have at the lesion at multiple sites. Thickening of the stalk or interruption of the stalk caused by germinoma may result in hyperprolactinemia. Radiation at varied doses has different effects on your puberty. So low dose radiation results in loss of negative feedback and early puberty, whereas a high dose radiation greater than 18, cumulative dose greater than 18 centigrade, will result in destruction of your gonadotrophs and permanent delayed puberty. Turner syndrome is an important clinical presentation in a child presenting with delayed puberty, is something that you need to consider about. So these children will classically have all the features of Shark's defects like Madelung deformity, a wide carrying angle, brachymetacarpia, or will have features of lymphedema, that is web neck, wide shield shaped chest. And even in the absence of these characteristics, if you have a short girl with delayed puberty, one needs to rule out Turner syndrome before looking at other pathologies. So in Turner syndrome, up to 30% may have spontaneous breast development. However, only 6% have spontaneous menarche, and spontaneous pregnancy is achieved in less than 1% of these children. Karyotype is essential to understand the degree of mosaicism, to rule out Y cell line, to be able to predict the associations. As you know that ISOQ is associated with autoimmune thyroiditis, whereas XIST ring chromosome may be associated with mental retardation and significant other challenges. The FSH levels need to be interpreted in the light of bone age. So if your bone age is delayed, especially less than 10, your FSH will be low or normal. And that does not rule out Turner syndrome. So that needs to be taken in mind. AMH is a better marker. It will decline earlier. When your FSH has risen, your AMH is definitely low, and you can do nothing for oocyte preservation in such children then. There are various genetic defects of ovarian development which are responsible for 15 to 20% of primary ovarian insufficiency. So when you have a child with primary ovarian insufficiency, the first thing you need to rule out is Turner syndrome. Once you've ruled it out, then you look into the genetic defects, you look into the autoimmune defects. So WT1 is associated with Dennis-Drash and Fraser syndrome, and it is an important part of early ovarian development. NR5A1 is again a homozygous mutation results in additional adrenal failure along with gonadal failure. However, heterozygous NR5A1 defects may present with isolated gonadal failures. WNT4, RSPO1 are again involved in ovarian development, FOXL2 defects, NOBOX, FIGLA, GATA-A4 inhibin. All these defects will result in defective ovarian development and primary ovarian insufficiency. Classically, trisomy 18, 13, 21 are associated with defects in ovarian development. However, pregnancies have been seen with in girls with Down syndrome. Genetic disorders like galactosemia, myotonic dystrophy, and defects in DNA repair like ataxia, telangiectasia, and Fanconi are also associated with defects in ovarian development. Steroidogenic defects again will result in, especially those resulting in defective estrogen production, will present with delayed puberty. So your proximal defects, side chain cleavage and star, while these will not have atypical genitalia in a female, they will present with delayed puberty. Classically, as we know with star, it is a delayed manifestation in girls because in every cycle, some steroids are produced and there will be a progressive loss. Unlike in boys, where during the fetal period itself, there will be destruction of all the steroidogenic cells, resulting in atypical genitalia to start with. Defects in 17-hydroxylase deficiency, aromatase deficiency are again other steroidogenic defects that you need to think of in girls with delayed puberty. So your girls with ovarian steroidogenic defects, you need to look for hypertension, which may be a marker of 17-hydroxylase deficiency. Now, one needs to be careful that it could be an XX individual with 17-hydroxylase or an XY individual. Both of these can present as a female phenotype with delayed puberty. Checking BP will give you a clue. Looking at the electrolytes may give you a clue. The diagnosis is established by DOC and 18-DOC levels. Star and side chain cleavage may have features of salt wasting and low metabolites. POR defect will have 17, 21 and aromatase combined defects. So they may have mild salt wasting and a polycystic ovarian appearance. Classically, these girls will have high 17-OHP and low androstenedione levels. 17-beta-HSD3 may have normal mineralocorticoid but low androstenedione to testosterone ratio. Aromatase deficiency will present with hyperandrogenism and ovarian cyst. History of maternal virilization during pregnancy may give you a clue, but the diagnosis is finally established by doing a genetic test. A very unique presentation is that of GNAS1 defect, which is pseudo-hypoparathyroidism. The primary defect here lies in post-receptor signaling. So your GnRH is working fine, your LH-FSH are working fine, your LH and FSH receptors are working fine. But beyond the level of receptor, the post-receptor signaling is defective here. So you will have mildly elevated LH-FSH levels. These children may present with hypocalcemia, hyperphosphatemia, and high PTH levels. They may have classical AHO, that is the Albright hereditary osteodystrophy phenotype, that is round faces, a short, stocky build. They may have subcutaneous calcifications. And again, like mildly elevated LH-FSH, they may also have mildly elevated TSH levels due to, again, the post-receptor GNAS1 signaling defect. As I had already mentioned, in a child with primary ovarian insufficiency, first you need to rule out Turner syndrome. But once you've ruled that out, you need to think of steroidogenic defects, immune endocrinopathy. Now, the immune endocrinopathy can result in primary or secondary delayed puberty. So somewhere it could be somewhere like it did not start at all, or it stalled after starting. 10 to 15% of these cases have seen ovarian reversibility with progression of puberty. Classically, these children will have antibodies to 21-hydroxylase, 17-hydroxylase, 3-beta-HSD enzymes. And common associations that you need to rule out are adrenal insufficiency, thyroid disorders, celiac disease. So the associations can be APS1 or APS2, and you need to work up for cortisol levels, CBC, B12 levels, calcium, phosphorus, ALP to rule out your APS1 hyperparathyroidism and TSH levels. An important part of delayed puberty that one needs to think of with rising cancer levels in a child who was treated is late effects of cancer treatment. So your radiation as well as chemotherapy drugs can both result in delayed puberty, and radiation, either scattered or direct, can result in primary ovarian insufficiency. The tolerability for radiation is greater for a prepubertal ovary as compared to a pubertal ovary. But any dose greater than 20 gray has a 50% chance of causing delayed puberty. Alkylating agents like cyclophosphamide with a cumulative dose of greater than 200 milligrams per kg cisplatin anthracycline are all associated with delayed puberty. They can also lead to anovulation and a premature menopause. Classically will be a high FSH levels as seen with primary ovarian insufficiency. So if your radiation is or if your alkylating agent was used during puberty, it has a greater chance of causing a stalled or delayed puberty rather than giving it in a prepubertal child. You can prevent it by doing an oopexy and sidelining the ovaries from the zone of radiation. Oocyte storage and imatinib therapy are under evaluation and may help in preserving long-term fertility. To assess the progression of puberty in these children, estradiol, FSH, and AMH levels are helpful. And management of delayed puberty once it occurs is with estradiol and subsequent pubertal induction, as one may do for other causes. Thank you.
Thanks a lot, Dhwani, for this wonderful discussion. And you've really taken a lot of aspects of the causes of delayed puberty. And what we'll now be doing is to look at the overall processes in terms of how do we assess and manage. So we already discussed about pathophysiology. We'll now focus predominantly with regards to assessment and management. So the key questions that a physician has to answer with regards to a girl with delayed puberty is it really delayed puberty? If it is delayed puberty, is it physiological or pathological? And finally, what is the cause of delayed puberty in that regard? So delayed puberty is defined by lack of thelarchy by around 13 years of age and lack of periods within 3 years of the onset of thelarchy. So we are talking not only about delayed puberty, but also about stalled puberty, which I said may be a marker of a serious underlying disorder from that perspective. Secondary amenorrhea, that is another marker of stalled puberty, is defined as lack of period for 90 days in somebody who has got regular periods and 180 days who may have an irregular period. We also need to be aware that there could be anovulatory features which may suggest an impending ovarian or a pituitary failure. So this may not truly be delayed puberty, but they may suggest that there are issues which are happening. And for that, we need to understand the normal number of periods which are there. So in the first year, less than 4, 2 to 4 years, less than 6, and fifth year, less than 8, and beyond that, less than 9 is considered to be delayed puberty or anovulatory cycle. So from a pure delayed puberty perspective, no thelarchy by 13 years and no menarche within 3 years of thelarchy is suggestive of a clear-cut delayed puberty from that regards. Now, once we know that this is delayed puberty, we need to decide whether this is at 30%, this is physiological, in which we may just have to wait and watch, or maybe give a just small dose of estrogen, or a pathological cause where we need to do a lot of workup from that regards. Now, the clues to pathology, so because physiology is common, we don't want to miss pathology, is that if you have a girl who has a normal growth, normal development, and normal pubic hair. These three signs will say, okay, there is something wrong in the girl and I want to evaluate further in that regard. So you can do a basal and stimulated LH levels. If they are low, they are suggestive of a pathology. On the contrary, a short girl who is looking healthy, has a delayed bone age, has no pubarchy, and has low basal and stimulated LH, that is constitutional delay of puberty and growth most likely from that scenario. Now, hormonal evaluation, we already discussed that LH is more important in terms of the onset of puberty, but FSH is more important in girls because this may be a marker of ovarian cause. The level of FSH elevation in girls is substantially higher than boys because they have a lesser amount of inhibin B. And this is something which is important from that regards. Very often we have to differentiate constitutional delay from permanent hypogonadotropic hypogonadism. So a basal LH below 0.1 and a stimulated LH below 5 is suggestive of a scenario, is clearly suggestive of hypogonadotropic hypogonadism, while if basal is more than 0.3 and stimulated more than 5 suggests a case of constitutional delay of puberty and growth. Once we know that this is a pathological cause, we have to go further in terms of the causes of delayed puberty. And as I said, pubic hair and breast development give you a clear-cut clue. If you have no breast development and pubic hair development is there, this means that the pituitary is not working, but the adrenal is. This is a classical case of GnRH deficiency. Absence of breast and pubic hair suggests either there is a constitutional delay of puberty in growth or there is illness which is delaying adenarche. Rarely, this could be because of a multiple pituitary hormone deficiency or a steroidogenic defect. If, however, there is a girl who has a normal breast development and no or sparse pubic hair, this may be the only marker of androgen insensitivity syndrome. While if everything is normal, breast is normal, pubic hair is normal, but there are no menstrual cycles, this could be a malformation. So always club your pubic hair with breast to get a good diagnostic clue in terms of evaluation. Subsequent pointers include the presence of obesity, which could be an indicator of syndromes like Prader-Willi syndrome, Turner syndrome, pseudohypoparathyroidism or leptin deficiency, polydactyly, typically the Lawrence-Moon-Beadle syndrome, abnormality in hearing, which is common in the setting of Turner syndrome, charge or pseudohypoparathyroidism, brachymetacarpia, again a marker of Turner or pseudohypoparathyroidism, short stature, which could be is very severe thing of Turner or MPHD. You can also think of celiac or constitutional delay of puberty in growth in somebody who is short and who has a delayed puberty. Hypertension is an important clue, so always measure your blood pressure. If it's very high with hypokalemia, think of 17-hydroxylase deficiency. Otherwise, Turner syndrome, also look for forelimb blood pressure in that perspective. So once you know this is hypogonadotropic hypogonadism, the key question is it a functional hypogonadotropic hypogonadism or it's a true GnRH deficiency? And in this regards, if your growth is less, bone age is less, pubic hair is absent, that goes more in favor of a functional cause, while normal height, normal pubic hair and a normal bone age suggests an isolated HH in that regards. And GnRH stimulated LH would also give you a clue. So functional causes will look like constitutional delay of puberty and growth, but they will look sick. While if you have a short girl with delayed puberty, no pubic hair looking not sick, think of CDGP. Sick, think of functional cause in that regards. Always do a prolactin level systemic workup before you go ahead in terms of doing further imaging in that regards. Dhwani has already said that MRI is essential as part of workup. So when a girl comes to you with delayed puberty, do a screening test, and this I would include CBC, liver function, kidney function, celiac evaluation, thyroid profile, and prolactin. If all of them are normal, then do a gonadotropin level in that perspective. The FSH is high, and usually when you talk about girls, there is no confusion. The levels will be somewhere like 15, 20, even 100 in that regards. This is the scenario you want to look at the karyotype. Then if you then think of other genetic causes, if the Turner is ruled out, or some other autoimmune causes in that regards. If, however, you have hypogonadotropic hypogonadism with low levels of FSH, are there any pointers to permanent hypogonadotropic hypogonadism like anosmia, synkinesia, or CNS features? In that scenario, you don't need to worry. Otherwise, you can go ahead with a GnRH analog stimulated LH. If it's above 5, this suggests constitutional delay of puberty and growth. If the level is below 5, that's permanent. And if there are pointers to HH, again, this is permanent HH. And in this scenario, you have to get an MRI and a cortisol. So evaluation is very simple. Go for simple chronic diseases followed by FSH, which will guide your evaluation towards karyotype if it's high, MRI and other causes if it's low. In that regard, we'll run through a few cases, and this is what I discussed earlier. A 13-year-old girl with concern for delayed puberty. Unnecessarily, this case had a lot of workup. Advised MRI head ultrasound was showing absent uterus. So this is a scenario in which if it's too early, wait and watch. Do not do too much workup in that regard. 16-year-old girl with delayed puberty, no breast, no pubic hair. So we're talking about CDGP versus a systemic illness right away. Height is less, so again, very, very short. Weight is also less. LH and FSH was low. And we have developed a puberty interpreter, which we'll talk a bit later, which guides your evaluation based upon that. And this tells you that this is, you need to do a proper workup in that perspective. Now, she also had anemia. She had clubbing. So this is a classical case of celiac disease. If you have short girl who is looking sick with lean, think of celiac in that perspective. 12-year-old girl with growth failure. Of course, we've got all the clinical features of Turner syndrome. There is webbing of neck. There is widening of the angle. There was brachymetacarpia, brachymetatarsia, and all features were there. Somebody did a FSH level, which was high and was advised growth hormone. Now, as Vania said, FSH may be normal in the early age group when the bone age is retarded, but high FSH with classical features only also may suggest Turner, but you need to always do a karyotype to identify a Y cell line, which was not done in this case, and she presented later to us with abdominal lump, highlighting the importance of doing a Y line. So this is very, very important. Do a karyotype in a girl with Turner syndrome before you really go ahead and making a diagnosis from that regards. Now we have a 16.5-year-old girl with stalled puberty who had onset at 12 years and no development for the last 3 years. This is something I'm really concerned about. There's something new which has happened in this girl. She is having a reasonable height and weight. LH and FSH is very, very low. And now what we need to do here is to look at other features. There's galacturia, but her prolactin level is normal. So my first diagnosis with galacturia, with stalled puberty is a possibility of hyperprolactinemia, but the galacturia is there, but prolactin is not high. Somebody got an MRI head which showed a large lesion. So this is a classical case of a hook effect. If your prolactin levels are exceedingly high, if you do not do a diluted sample, you will have a falsely low level of prolactin. So here with dilution, the prolactin was found to be high. This was a classical case of hook effect. 16-year-old girl with delayed puberty, breast stage 1 and stage 3 pubic hair development. The girl has a height of 149 and weight is 37. So this girl is not bad in terms of height. It's very close to her parental height. Breast stage is there, but pubic hair is stage 3. LH, FSH is low. So this is a discrepancy between pubarchy and thelarchy going more in favor of a hypogonadotropic hypogonadism. She also gave other clues of anosmia and deafness, which suggest a possibility of Charge syndrome or CHD7 defect. So if you have a discrepancy in which pubarchy is present, but thelarchy is not there, think of a hypogonadotropic hypogonadism. And if there are features like anosmia and deafness, you may get a direct clue for Charge syndrome like in this case. 17-year-old girl with secondary amenorrhea, in this case was alluded to by Dhwani in terms of her presentation, and we were sent to us as a large pituitary tumor. But when we saw the child, she had a high prolactin with galacturia. This was labeled quote unquote a prolactinoma. But the child had all the features of hypothyroidism. Her FT4 was very low, TSH was exceedingly high, and this was a classical case of pituitary hyperplasia, a thyrotrop hyperplasia because of hypothyroidism. And once we corrected it, there was an improvement not only in clinical features, but also in terms of other clinical scenario. 14-year-old girl with delayed puberty, no breast, no pubic hair, no periods. Her height is 144, weight is on the higher side for the height. FSH is slightly high, but not as high as Turner syndrome. LH is slightly high, karyotype is XX. So what else to look at? And here also Dhwani gave you a clue that pseudo-hypoparathyroidism may present with a resistance to gonadotropin. So she had got a brachymetacarpia, there was deafness, there was hypocalcemia, hyperphosphatemia, and high PTH, suggesting pseudo-hypoparathyroidism. So this is something you have to be worried about in that regards. 14.5-year-old girl with delayed puberty, no breast, no pubic hair, height is 145 centimeters, weight is 36 kg on the lower side, FSH is high, LH is normal, karyotype is XX, there is hypertension. So this is a very, very interesting scenario. You have a girl who has got delayed puberty, sexual infantilism with hypertension, and your karyotype is XX. So I think this is a clear-cut clue that you're dealing with a 17-hydroxylase deficiency. So subtle clues like looking at blood pressure can give you the right diagnosis in that regards. We have developed a puberty interpreter, which is a mobile application-based app which provides guidance with regards to evaluation of puberty based upon very few clinical inputs, based upon all the algorithms which we talked about. And once we validated it, we found it to be highly effective in terms of preventing unnecessary workup and missing of pathological causes from that regards. Moving briefly with regards to the management of delayed puberty in girls, what we can do theoretically is we can give estrogen, of course, to induce puberty, which is the most likely treatment. We can think of gonadotropin treatment in somebody who has a hypogonadotropic hypogonadism. There are studies which have looked into GnRH pump-based therapy and the use of kisspeptin, but predominantly we will focus on estrogen and gonadotropin for fertility in hypogonadotropic hypogonadism. If somebody has an ovarian problem, we of course can only give estrogen. In certain scenarios, specific therapy may be possible. For hyperprolactinemia, they will respond wonderfully to D2 receptor agonist. If there is a prolactinoma, macroprolactinoma, long-term treatment, microprolactinoma, up to 2 years treatment is required. Anorexia nervosa, we have to do a nutritional rehabilitation. Once the weight becomes more, they will have increase in fat and the periods may happen. Celiac disease respond dramatically to gluten-free diet. Systemic disease, specific treatment is required. Now, estrogen, the route is very important. We have an option of either giving estrogen via the oral route, wherein it goes to the liver and then reaches the circulation, or we give a topical scenario in which we just apply. So when we give orally, it is going to the liver. It is affecting IGF-1 production, resulting in lower level of IGF-1, increased level of protein C, resulting in thrombotic tendencies, increased lipase, resulting in dyslipidemia. So oral preparation may have a lot of complications in that regard. Transdermal preparation, on the other hand, will directly result in the delivery of estrogen to the blood. They will not have an effect on IGF-1, thrombosis, dyslipidemia, or hypertension. These are the agents of choice, but they are not readily available and are expensive in that regards. So we have an option of transdermal versus the most commonly we use is 17-beta estradiol. The dose is 2 milligram per kg per day. We have to start from a very, very low dose. The effect on IGF-1 is, of course, more with 17-beta along with hypertension and thrombosis risk, as we have discussed in that perspective. So the estrogen preparation, which was earlier used, was ethinyl estradiol. The adult dose typically is around 10 to 20 microgram per day, and typically we should start from around 10% dose. But this is a very strong preparation. We should better avoid ethinyl estradiol. What we use is ethinyl estradiol valerate. In that, we start off with 0.25 milligram and then build up to adult dose of 2 milligram over a 2-year period with a physiological development. Transdermal estrogen, the options are to start off with 3 to 7 microgram per day by cutting the patches and applying that on alternate days to begin with, and then gradually build up to the adult dose. The benefit of transdermal estrogen is that it doesn't have an effect on IGF-1. In girls who have constitutional delay of puberty and growth, if they are getting too late, we may push the puberty by giving a small dose of estrogen, like we give testosterone in boys, 0.25 to 0.5 milligram daily for 3 to 6 months. And this often kickstarts the puberty in that scenario. Those who have a permanent hypogonadotropic hypogonadism or hypergonadotropic hypogonadism, we start with 0.25, build up over a 2-year period to a 2 milligram dose, and then only considers adding progesterone. If a progesterone is given at an early stage, it compromises the breast and uterine development and should therefore be avoided. The fertility option in hypo is gonadotropin, which we'll discuss a bit later. For hypergonadotropic hypogonadism, the ovarian problem, we can think of a oocyte donation. Progesterone should be added only around 2 to 2.5 years after the onset of pubertal induction, and we could give it or the periods have happened. The options are medroxyprogesterone or micronized progesterone. Micronized progesterone are preferred, but they are more expensive in that regards. They should only be given either at vaginal bleeding or the endometrial thickness is more than 5 mm, because too early progesterone prunes the breast development and the uterine development as discussed. So for self-limited delayed puberty, start around 13 years, and a bone age above 12 years, start with estradiol valerate at 0.25 to 5 milligram for 6 months and gradually look for pubertal response, and you will find an increase in LH and breast development, and this will be usually a process which will improve. For permanent HH, we start off around again at 12 years of age. The protocol is estradiol valerate 0.25 milligrams, increased by 0.25 every 6 months to adult dose of 2 milligram by 2 to 2.5 years. The follow-up will be to look at growth, progesterone if there is a bleeding or the endometrial thickness is more than 5 mm. Breast size, however, will remain compromised with multiple pituitary hormone deficiency. We typically have periods by around 2 to 2.5 years, and we have to monitor blood pressure in that scenario. For hypergonadotropic hypogonadism, the options are oocyte extraction and donation, but often by the time they come to us, the oocyte is already not there. So most girls with Turner syndrome don't have that option. Oocyte donation therefore becomes an option, and oocyte extraction can be done after 12 years, but it's an invasive procedure. The future direction, of course, is ovarian transplant and stem cell based therapy in that regards. So we have tried to cover the entirety of delayed puberty from that perspective, including the pathophysiology. We then move forward in terms of etiology, in terms of evaluation and management. Before we go ahead in terms of the OSCE, we will start off with the OSCE now. Vibha, you can share the screen now.
Okay, sir.
So we'll have questions. Some of them will have case scenario based, and some of them will have a quick answer questions. So you have to answer that on a Q&A chat, and we will read out the person who answered it the first and correctly. So over to you.
Okay, sir. Thank you, sir. So there will be 5 questions, and every questions will have 4 or 5 parts. So you have to answer in question 1, there are 5 parts, and so write 1 and answer for the 5 parts. So I think approx 2 minutes will be given for each question, and then I'll change the question. Okay, so let's begin. First, I'll read the question and then you have to answer. So here's the first question.
Full screen, full screen.
Yes, sir. A 16-year-old girl presented with delayed puberty, and on examination, she has a stage 1 breast and stage 1 pubic hair development, and has a height of 135 centimeter and a bone age of 10 years. Now the timer starts of 2 minutes. What is the definition of delayed puberty? Write only the year.
So
Name the hormones regulating breast.
Maybe we'll give some time to, we'll see how people are responding. So all of you can just put in your answer on the chat, on the Q&A. Yeah. So not achieved Thilarki by 13 years. So everybody is agreeing. Dr. Sandeep, Dr. Medha, Dr. Arul Nathan, Dr. Adele, Dr. Edisola, all of them have mentioned 13 years. So I think this message has gone really well. No breast development by 13 years.
Okay,
Next
fine.
one.
Now name the hormones regulating breast and pubic hair development.
Yeah. So I think this is something which we discussed in detail. So Dr. Medha has already mentioned, just hold on. So give people answer. So Dr. Medha has mentioned breast estrogen, pubic androgens. Anything specific on androgens? We are looking at a more specific answer for androgens. That would be, anybody is coming up with the adrenal androgens, that is DHEAS. Dr. Shubhadeep Paul has mentioned DHEAS, Dr. Sheikh Mahim. So yes, I think we're going fine from there. The next question.
So what is the likely finding on the ultrasound for uterus, especially in this case?
Yes, so this is very relevant. This is just that she has breast stage 1. So what you may find from the radiologist, uterus paper thin use, yes, you can have absent uterus, may be missed. So I think that's an important message that we wanted to give, tubular uterus. So I think both are right, but there may be a few chance that somebody who is not that experienced may miss the uterus also. Yeah,
Yes.
carry on.
What are the key findings that you should look for in the examination in this case?
So maybe one finding you can mention.
Yeah, one finding, any one finding.
Most important finding, of course, in a short girl who has delayed puberty. Pubic hair, yes, a lot of people have talked about pubic hair. You have mentioned pubic hair already. Stage 1 pubic hair is there.
Yes, it's given.
So something else, one clue, you of course have to look the whole child, but one thing which will give you the diagnosis would be Turner stigmata. So wide carrying angle, brachymetacarpia, web neck. So I think the message was very, very clear. And
last one is what is the most critical investigation that you would do in this case?
yeah, short girl with delayed puberty, the most critical investigation. Already we've got Dr. Medha who has mentioned FSH, Dr. Adiokia has mentioned karyotype. So yes, so I think both of them are important. So FSH, karyotype, I think the answer is pretty clear. So I think we'll move forward to the next one, Dr. Vibha.
Next question directly, sir.
Yes, yes.
So here's the next question. We have this 14-year-old girl presented with delayed puberty and growth failure. She had a height of 135 centimeter and a weight of 35 kg with a BMI of 19.2. On examination, she had a breast stage 1 and pubic hair 2 with a webbing of neck and brachymetacarpia. She presented with an abdominal lump on follow-up. So what is the most likely diagnosis? I think this is the easy one.
So I think this is very, very clear that this is case which we discussed also. So this is Turner syndrome with Y cell line. Dr. Adele, Dr. Edasola, both have mentioned Turner syndrome with gonadoblastoma, right? The most next point, Vibha?
What are the most helpful investigation for making a diagnosis in this case?
So yes, so we are looking at karyotype. Dr. Shubhadeep Paul or Dr. Arul Nathan have mentioned karyotype. So I think Dr. Adele, so I think yes.
Yes, sir.
Karyotype and FSH.
And what should be done to prevent the abdominal lump in this case?
Yes, so I think this is very, very important. So what could have been done and what should have been done earlier?
Yes.
So to prevent the lump, if you have a Y cell line, you have to, let's see what people are saying, do a gonadectomy. Dr. Shubhadeep Paul is mentioning gonadectomy, remove the gonads, gonadectomy. So I think very clearly any girl with Turner syndrome, we should do a Y line if there is a suspicion and get a gonadectomy. Yeah, carry on.
What are the key examination findings associated with lumps? Then what will you get if the patient is having lump?
Virilization, true. So if there is a Y line, if there's a gonadoblastoma, you can have virilization. So I think that was a very good answer, Dr. Arul. Yeah.
What are the 3 most important screening workup to be done?
This is clearly a case of Turner syndrome. We should look at various things. So 3 most important. I think people will take time to put in. Echo has already come. Hearing, echo and ultrasound, Dr. Sandeep. Dr. Adele, thyroid, cardiac, hearing, yes. Maybe add renal as well. So that is a very, very clear-cut case of Turner's in which we should have missed the Y line. Carry forward.
Coming to the next question. We had this 14-year-old girl, sorry. This on examination, her height was 144 and weight 36. Both were low, but appropriate for born age of 11 years. She had a breast stage of 1 and stage 1 pubic hair growth. Lab investigation showed an LH of 0.2 and an FSH of 1.1 with an estradiol of 30 nanogram per day. So what is the most likely diagnosis?
So girl with delayed puberty who is slightly short and has no pubic hair. So people are already going into CDGP. Do you agree, Vibha?
Yes, sir, CDGP.
So this is classically CDGP. So Dr. Adele, Dr. Arul, Dr. Sandeep, Dr. Edosala, all are agreeing to CDGP. Yes.
And what are the differential diagnosis in this case?
So I think differential diagnosis of no pubic hair and no
No
breast
breast.
development. So other than CDGP, MPHD, very good, Dr. Adele. What else are we looking at? Maybe a systemic illness.
Systemic MPHD.
Yes, Dr. Sandeep is talking about, or a steroidogenic defect.
Steroidogenic.
So all three have come in. Dr. Sheikh has mentioned steroidogenic defect. Yes. So
What are
next.
the helpful tests that will help in making a diagnosis?
So yes, here you are pretty okay, but you want to maybe do some tests to exclude some disorders and do some stimulation testing.
Yes.
Yes, so somebody is coming up with that. Systemic illness should be ruled out. That's important. TTG, KFT, yes, definitely, Dr. Mehta. So that will be an important thing on that.
And how would you manage this case if this is
GNRH
severe?
stimulation as well, Dr. Arul, which is fine. Yeah. How will you manage this case? I think this is important. So Dr. Adosala is mentioning reassure, which is also acceptable because bone age is 11 years.
Yeah,
If it was
but
about 12, we should definitely give estrogen. But if somebody says estrogen, we are not also against because she is 14 years old already. So Dr. Shubhadeep has given the answer of estrogen / observation. So
yeah.
I think low dose estrogen for 3 to 6 months. Yeah. Next case, please.
Next question. We have 16-year-old girl with primary amenorrhea and the normal breast development. On examination, she has a tall height of 163 centimeter with a breast stage of 4. And she had no pubic hair. So what are the differential diagnoses if we look for the stage 4 breast development and no pubic hair?
So I think we want one diagnosis and already people
Yeah.
have started. Dr. Medha, Dr. Sandeep, Dr. Arul Nathan, Dr. Tahini, all are saying AIS. So I think that's the clear cut message.
And what
A
physical exam?
tall girl with no pubic hair, a lot of breast development. So complete androgen insensitivity syndrome, Dr. Adele. Correct. Next question.
Which physical examination will give you a clue to the diagnosis?
So yes, Dr. Medha is saying presence of no pubic hair. That is something there, but something more.
Yeah.
We are looking at a positive finding, not a negative finding. Blind vaginal pause, tall, Dr. Sandeep. Anything else which is very easy to identify? Tall, everybody's forgetting the main thing. So this is a girl, but she had a karyotype of.
So that will confirm the.
Yeah, so people will know, but what is there? So that's very important. This is a DSD. So you have got
inguinal gonad there.
Inguinal gonad, that becomes important. Yeah. So next question.
Which investigation will confirm the diagnosis? Definitely, sir has answered. And how would you manage this case?
So you can get a karyotype done and then you can have a high LH, high FSH, high testosterone. That will be another clue to diagnosis there. Yeah, management of the case again is very, very important. You will do gonadectomy, but when? So generally, so Dr. Sandeep is saying gonadectomy. So Vibha, when will you like to do gonadectomy?
Sir, we do gonadectomy after the puberty because during the time of puberty, we require this hormones, even the testosterone for the development or the mineralization of the bones. So we
the
generally
chance
do
of
after the
gonadoblastoma is very low before puberty
puberty,
in
right.
these girls. So we should avoid that. Yeah. Should do it after that. Okay, last case.
So coming to the last one, we have this girl who presented with delayed puberty of stage 1 breast and pubic hair. The pubic hair is also stage 1 and she had a height of 135 centimeter and the weight of 28 kg. Investigation showed low LH and FSH levels. On the examination,
Already people have mentioned celiac disease. So I think this is a very classical case of celiac. Dr. Adosala is talking about celiac disease, but it can also be renal failure. Similar finding, we've seen patients with renal failure presenting.
And what key finding on examination would give you the clue to the diagnosis?
Yeah, and thalassemia. So I'm just not, I think with anemia and delayed puberty, if you want to carry on some other possibilities, Vibha. So one we talked
renal
about
failure, as you said, and again you have mentioned the thalassemia. It could be the cause of delayed puberty because of the repeated multiple blood transfusion that can lead to the delayed puberty.
We need to be cautious on that regards.
Yeah.
Okay. So finding examination.
Examination, like clubbing.
We are looking for answers.
If we are looking for, yeah. And
So
what screening test is helpful in this case?
So clubbing is mentioned by Dr. Arul, screening investigation. Of course, we have to do TTG. Dr. Shubhadeep, as mentioned, we also have to do other things as well, like creatinine, reticulocyte count, CBC. So all the other workup has to be done on that. Yeah.
Which investigation would confirm the diagnosis?
Provided you have a high TTG, then you will go ahead for a biopsy. Dr. Sandeep has already mentioned.
And definitely the management of the case, it's easy one.
Is gluten-free diet. So I think that was the last case, Vibha.
Yes.
So I think this was a very, very interesting session, and we have tried focusing on different aspects of pubertal aspect. You can stop sharing the screen. And we discussed a lot. There are few questions which were there before that, so I'll try to see if there one. Dr. Adelaide is talking about a phenotypic girl with XY karyotype. The cortisol is normal, hypertension is present. Does it can still fit in 17-hydroxylase, or there is another issue happening here? Okay, so this is a case XY with a phenotypic girl with hypertension. I would say strong possibility of 17-hydroxylase. That's the most likely thing. Cortisol may not be of much consequence. It is usually normal because the ACTH is pushing there. So in this regards, you should look at potassium. If there is hypokalemia, this may be giving you a clue. If there is a doubt and you don't have a genetic diagnosis available, give us a dose of steroids, hydrocortisone at a replacement dose, and see if the blood pressure falls, because they will respond very well to replacement. Dr. Adesala, Dr. Dharmendra Panchal is asking when to prefer bromocriptine over cabergoline in hyperprolactinemia. What dosage recommended? So generally speaking, bromocriptine is now not recommended because it has got lesser efficacy in terms of decreasing prolactin, in terms of decreasing the size of pituitary lesion. The only condition in which we tend to use bromocriptine is in pregnancy, the first trimester of pregnancy, where it is considered to be a slightly better agent compared to cabergoline in that regards. So I think this was a very, very extensive discussion, and a lot of participation was there from a lot of people. We already have around more than 100 answers which are there in the chat. So I think Vibha has done very good in terms of raising the interest with the OSCE. So I think before we conclude, we'll have final words from Vibha and Dhwani about delayed puberty, the key messages they want to give.
If we have a goal with delayed puberty, like no absence of breast development after the age of 13 years or stalled puberty, definitely the first thing is to ask for the family history, whether there is a history of delayed puberty in the mother or so, because this is very important in ruling out the CDGP. Another thing is to look for is to go through the thorough examination, because very subtle clue in the examination will give us clue to the diagnosis, like first ruling out the systemic diseases, ruling out this Turner stigmata, even for the clubbing, Pella, each and everything would contribute to the diagnosis. So examination is very important, and the family history, I would say. So these would both of these in combination with, and the breast development along with the growth of pubic hair, as you said, whether there is a
so a comprehensive
with,
examination is something which is very,
very
very
important.
crucial. So Dhwani, your last messages?
Thank you, sir. So again, when you have a girl with delayed puberty, keep your eyes and ears open for a pathological cause. Usually the breast staging and pubic hair staging will give you a rough clue to the pathway that you need to take to evaluate the cause. And based on that, you can then go on to investigate, avoiding unnecessary investigation. No need to do all panel of investigation in every child.
Yes. There are a couple of questions we have just come up before we summarize. Dr. Samar is asking why potassium in 17-hydroxylase deficiency. So we are expecting an increased mineralocorticoid effect. So hypertension along with hypokalemia. That will be a clue of that. So that's why potassium is being asked for. Dr. Adosala asked about puberty interpreter, a mobile app. Yes, it is part of our MedEClasses mobile application. It's got around 50 pathways, around 15 interpreters, including puberty, growth, obesity, and a lot of others which have already been validated in different studies. So this is available as part of the mobile application. So once again, I'd like to thank all of you for joining from across the world for this time. I'd like to thank Vibha and Dhwani for the wonderful presentations. And we'll look forward to meeting you again next month with a session on delayed puberty in boys. Thank you.